Good morning, everybody. We are about to start the next session. I am joined by my co-moderator, Akos Varga here. He is from Medical University of South Carolina. I'm Jeff Mackey from the University of Colorado. And we had 3 speakers lined up for this session, but unfortunately, one is not going to be here, which will give us a little bit of extra time to A, not get behind, and B, have a little bit more time for questions. We'll then switch out after these 2 talks, moderators, and keep going with some more talks and then get into some power pitches. But our first speaker is going to be from UCSF, Dr. David Solaner, talking about lighting up the vessel's advantages and challenges of contrast-enhanced MRA. So David, welcome to Budapest.
Thank you very much. It's a great pleasure to be here. I want to thank Judith for organizing the meeting and for inviting me to give this presentation today. So I have no conflicts of interest to disclose. I will mention that I will be talking a little bit about ferumoxytol, which is an FDA-approved agent for iron-deficient anemia, but is used as a vascular imaging contrast agent, is used off-label. So what I hope to cover today is the advantages and limitations of non-contrast MRA, to set a background for why we might want to look at gadolinium-enhanced, contrast-enhanced MRA, and also options for ferumoxytol-enhanced, contrast-enhanced MRA. And I'd also like to state that one of the major advantages of using a contrast agent in doing a vascular study is as part of a comprehensive vascular exam that not only looks at the angiographic effects, but at other aspects of the imaging, as we will see later. So, of course, the major advantage of non-contrast MRA is no contrast side effects. There is, when we're using contrast-enhanced MRA, as we'll see, a lot of challenges around appropriate timing of the acquisition relative to the delivery of the contrast agent. That is not an issue for non-contrast MRA, such as time of flight. And when we use non-contrast MRA techniques, not only do we get very good delineation of the vascular lumen, but there is often additional information in the vessel wall, which is not as heavily suppressed as it is in contrast-enhanced techniques. But non-contrast techniques do have their limitations and their challenges. In particular, there is a sensitivity to flow. There's a reliance on the inflow of unsaturated magnetization into the imaging volume, and that can result in saturation of flowing spins and reducing the coverage of our acquisition. The techniques are sensitive to flow motion and require appropriate gradients, motion compensated gradients, to refocus all the signal. And it's also very much dependent on flow directionality in most applications. Given the extended acquisition times, their non-contrast techniques are also sensitive to gross motion, not only patient major motion, but effects such as swallowing, breathing, and other effects such as that. Because of the sensitivity to flow, there's very often variable intraluminal signal strength. And as mentioned before, while in some regards an advantage that you have some signal from the wall, it reduces the lumen to wall contrast. So for these reasons, contrast-enhanced MRA provides some major opportunities. And the major feature that we exploit in contrast-enhanced MRA is the fact that once a contrast agent is delivered, there is a substantial reduction in the T1 of the intravascular flowing blood. Given that, this permits a larger Philip angle to extract greater signal to noise. We no longer have to worry about signal saturation and greater contrast to noise ratios and a better suppression of the background signal. Given the increased magnetization that's available for sampling, this permits the use of much higher bandwidth sequences and consequently the ability to have much shorter echo times and greatly reduced repetition times. Very much shortened repetition times reduces the total acquisition time from the order of minutes to the order of tens of seconds. And so we have a much reduced sensitivity to gross motion when we're using contrast enhanced techniques. And as mentioned before, whereas non-contrast techniques require motion compensation gradients, with the very short echo times that we use with contrast enhanced MRA, we have reduced dephasing and we can dispense with those more complicated gradient waveforms. And finally, this insensitivity to flow, this ability to attain a shortened T1 throughout the vascular territories provides the ability to have improved coverage. In general, with gadolinium techniques, the extravascular agents as a first pass acquisition is usually used. Very often we're looking at the arterial signal and timing is set to avoid venous contamination. Typically, the acquisition times are matched to the duration of the contrast enhancement. And this very typically results in acquisition times of the order of 30 seconds, which in turn constrain the resolution and coverage that one is able to acquire in those times. A typical protocol might require injection into, say, the antecubital vein, or a bolus injection to determine arrival time, and then the full dose. So it's typically, you have the injection of the contrast, and then following that at 1 second intervals, recapturing of the signal as it passes through the territory of interest to show the arrival in the arterial system, a little later in the venous system. And with that information, we can determine the transit time from injection site to arterial enhancement. Building on that timing information, we can then deliver the full contrast dose and set our acquisition such that the center of case space is sampled at the peak of the arrival of the contrast in the territory of interest. So again, as illustrated in this example, we see that contrast enhanced MRA provides the ability to have an extended coverage, a short acquisition time, and with first pass imaging, we were able to capture the enhancement of the arterial phase of the contrast passage. There's an example of why time of flight can sometimes fail. This is a MOTSA acquisition, multiple slab acquisition through the circle of Willis. And you can see in this circled area a somewhat strange appearance of the middle cerebral artery on this time of flight image. And what we have here is that, in fact, this acquisition, as all arterial acquisitions, was acquired with a superior saturation band. And at the point where this one slab was acquired, superior saturation actually was saturating arterial flow returning into the aneurysmal sac. On the contrast enhanced MRA, we have no such limitation. The entire volume is filled with the contrast agent, and so this illustrates situations where conventional time of flight imaging might fail because of this directionality dependence. Contrast-enhanced MRA has a strong ability for consistent, high-quality, uniform intraluminal signal enhancement. And as such is very helpful when we look at serial studies. So here we have a patient who's coming in for surveillance of an aneurysm of the anterior communicating artery and has multiple imaging sessions. In order to have consistent windowing and thresholding and segmentation, we use a reference segment of the vessel as a standard. We constrain our subsequent imaging such that the reference vessel volume remains unchanged. And therefore, any changes that we note here in this progressive scanning series, 4 different imaging sessions, we can very confidently assign to a growing aneurysm with robust image quality. And here we've been able to show that in a large patient volume, 600 studies that were performed, that the reproducibility is about plus or minus 5%, which when you think of it in linear measurements is of the subvoxel resolution consistency. So what are some of the challenges of contrast-enhanced MRA? First of all, contrast side effects, potentially, as Giles has expounded on earlier, and the cost of the agent. Technically, one of the major challenges is the determination of the optimal timing between injection and acquisition of the sequence. And this is more complicated when we're covering a large territory and the contrast agent has to travel from one arterial segment to a second arterial station. So there's not one single arrival time. And as mentioned earlier, the acquisition time is limited by the bolus passage and therefore giving us a trade-off in terms of resolution and coverage that we have to commit to. So to respond to the challenges of getting the appropriate timing window, the University of Wisconsin-Madison group came up with the TREX technique where rather than timing, you just acquire all phases and repeated sampling of the case space with oversampling of the case space center and borrowing outer regions of case space to fill in the different phases. And then you can post-acquisition select out the most appropriate arterial phase and review that. We should note that in these acquisitions that extend over extended periods of time, the magnetization strength throughout the territory is varying over time. So it's a convolution factor over case space. And so even though we have a nominal resolution, the true resolution is not always corresponds to what is nominally specified. And it's very hard to untangle what the true resolution is, given that unknown profile of the contrast passage. Again, here in a runoff study, we can see that the TRIX type of technique is helpful because we don't have one single arrival time, multiple arrival times as we go more and more distally, and therefore having this TRIX ability permits us to cover the entire territory in one acquisition. There are other approaches, other contrast agents that are becoming very exciting, been around for a little while now, but not yet hit the clinical mainstream. And I'd like to speak about one of these ultra-small paramagnetic ion oxides, paramoxetol, which, as mentioned, is FDA approved as a therapeutic for iron-deficient anemia. And it has the amazing ability that it has an intravascular half-life of around 14 hours. So this permits very extended scan times. And we can scan in steady state with true resolution, no modulation of the contrast through the acquisition. This is one of our earlier studies. We were looking at 2D thin slice time of flight at brachiocephalic arteriovenous fistula. And here with ferumoxytol, clearly the great ability to see more detail, better coverage. It is, however, a single-use vial and relatively expensive. Another acquisition, a patient, 3 different scans, all acquired back to back to back, 45 seconds, 2 minutes, 4 minutes, 1 millimeter isotropic 0.8 and 0.5. And when we zoom in, you can see that these smaller vessels, which are just a blur on the 1 millimeter, become much more apparent at higher resolution. You can see very small lesions, such as these HHT lesions. And because it remains intravascular, you can simply move on to the chest, to the abdomen, and acquire images of those territories as well. As mentioned, it's expensive. There is no separation of the venous and arterial phases. And but what I'd like to conclude with is some discussion of the fact that contrast agents are very important in the comprehensive vascular exam, where we want to look at the lumen, vascular inflammation in the wall, and hemodynamics. And all of these are enhanced by the use of contrast agents. So typical exam with and without, we do pre-contrast non-vascular imaging, vessel wall imaging, do the contrast-enhanced MRA, and follow up with post-contrast vessel wall imaging for wall enhancement and 4D flow. As an example, vertebral aneurysm, pre-contrast, contrast-enhanced MRA, post-contrast enhancement, and then 4D flow to look at the flow features within that aneurysm. Similarly with ferumoxytol, multiple stations covered, and then we can do the 4D flow acquisition here using a very large flip angle, 25 degrees, which gives us very strong contrast to noise, covering the entire heart, aorta, and the visceral arteries as well. So in conclusion, contrast-enhanced MRA provides motion robust, high contrast to noise visualization of the vascular lumen with good coverage. It's very effective for serial monitoring, and as part of a comprehensive vascular exam, we always need to consider the safety profile of the agents we use, technical challenges such as particularly bolus timing in first pass or venous contamination in steady state. So thank you very much for your attention.
So thank you, David, for that wonderful overview. We have probably no time for questions right at this moment, but afterwards, I'm sure David would be happy to talk to anybody. And
I'm going to introduce the next presenter, which is Bob Adelman from Evanston, Illinois. And it's a very unique moment for me that I can introduce him here in Hungary. It's a great friend and a longtime collaborator of mine. He, as usual, will talk about non-contrast MRA. Good luck.
Well, thank you very much. Great pleasure to be here. Wonderful audience and great location and great fireworks. So I'm going to talk about non-contrast angiography, which I've worked on for a couple of decades already. And it's a very interesting field, both academically and it's also very clinically useful. You've already heard why we might need a non-contrast approach to MR angiography. Risk of NSF, of course, with the older linear contrast agents, gadolinium deposition disease, environmental hazards of gadolinium. And, you know, given all these, you know, those risks have been greatly reduced with the use of macrocyclic agents, but I find practically in dealing with my clinicians, many of them still are concerned about the risks, even if it's not scientifically based. And so we often still get requests for non-contrast angiography. So even though you think you wouldn't necessarily need it, we still do in a practical sense. Now, there are a number of established and also a number of not established techniques for non-contrast MR angiography. I'm going to talk about the established approaches at the beginning of my talk, and then go into the fun, non-established approaches that I think have a lot of potential to really improve the quality of the exams and utility of the exams. So here we just have a summary. We have a number of standard techniques like time of flight, standard 3D balanced steady state-free precession, subtractive techniques, inflow-dependent techniques. We'll go through each of these. So one of the most straightforward approaches is simply to do a balanced 3D steady-state-free precession acquisition using either a respiratory bellows device or a navigator gating. And as you can see here, you can get some pretty good image quality with both techniques. In fact, here the spatial resolution is higher with the non-contrast technique than the first pass contrast enhanced MRA, which is not totally surprising because with non-contrast, we have the time to accumulate the signal and spatial resolution, whereas when you do first pass imaging, you're under pretty severe constraints in terms of acquiring all the data quickly. So the strengths of this non-contrast technique is very easy to use. You can get both high spatial and temporal resolution, but the scan times can be quite long and they're a bit unpredictable. We have occasional patients where the scan takes 10 or 15 minutes, which is really unacceptable. And at the end of that time, you may get a non-diagnostic study if they have very irregular breathing patterns. You don't distinguish arteries from veins, and it is sensitive to off-resonance effects with the use of a balanced steady-state free precession readout. Now, one of the more recent developments is the relaxation enhanced angiography without contrast and triggering, or REACT technique. This is a method that requires a very effective background suppression using a T2 preparation and inversion pulse, and it uses a Dixon technique to suppress the fat signal. And as you can see here, you can get some very nice looking images with this approach, and it has a number of benefits. For instance, it's relatively short scan time. You don't need ECG gating necessarily. It's flow independent, and it has wide anatomic coverage. On the other hand, hadn't been a lot of clinical validation with this approach. It doesn't distinguish arteries and veins, and it tends to have relatively lower spatial resolution versus the contrast techniques. But an interesting approach that I think will continue to improve over the coming years. Now, one of the most well-established techniques is the basic inflow-dependent 3D. I've talked about flow-independent before, but this one separates arteries from veins because it's inflow-dependent. You simply apply an inversion pulse over a broad area, typically used for renal artery imaging. You apply a delay time to let the fresh blood flow in, and then you use a 3D balanced steady-state free precession readout. Here's an example using navigator gating. You can also use respiratory bellows for this approach. And as you can see, you can get some very pretty image quality with this technique, sometimes better than you can get with contrast-enhanced imaging. Here's an example of a right renal artery stenosis with this approach. It's very easy to use, comfortable for the patient, relatively short scan times of typically only a few minutes. This technique actually is among the most well-validated non-contrast approaches, and it's commercially available with multiple vendors. On the other hand, when you have very slow flow, because it is inflow dependent, you may not see the full vessel, and you generally require a somewhat consistent breathing pattern. So pluses and minuses with this approach. Then the gated subtractive techniques, these are among the earliest techniques. In fact, the original MR angiography paper published in Science in 1985 was a gated subtractive technique by Van Wedeen, and it's come a long way since then. Basically, in systole, you tend to lose signal from the flow-related dephasing, and diastole retain the signal. If you use a balanced steady-state free precession readout, such as from DBL's group's work, you can use this for very nice images of the hand vessels, for instance. And if you use a fast spin echo readout, you can use it for the legs. So you get a high degree of background suppression. Number of commercially available versions of this. It's been pretty well validated to have good sensitivity and specificity. Some drawbacks, it has to be tailored for each patient. There's a little bit of variability between vendors and how well it works, and it is sensitive to misregistration artifact, but this is certainly a viable technique. Then the technique, the KISS technique developed by my own group, is very simple ECG-gated thin slice 2D acquisition. Very quick. You can do it in 7 minutes or less, typically for the going from the aorta down to the feet. Mainly used for lower extremity MRA, but applications are expanding. Here, for instance, we see the CTA in a patient with diabetes, and many diabetic patients have extensive calcifications. It makes it very difficult, even with the newer CT scanners, especially in the calf vessels, to accurately distinguish the calcium from the enhancing lumen. But with KISS, as you can see, there are no artifacts, and you can get very comprehensive evaluation. So there are pros for this. It's been proven to be quite accurate. There's no tailoring involved. It's a very simple push-button technique, and it's very sensitive to even slow flow in severe disease. There are potential artifacts in patients with highly tortural vessels with implants because it's a balanced steady-state free precession readout. Biggest problem, of course, is that most peripheral vascular imaging is now done with CT. So we don't get a huge number of referrals, but we do get these on a somewhat regular basis. All right, let's move on to some of the newer approaches. And these, I think, are quite interesting and have the potential for much better image quality, or the potential to provide additional kinds of information that maybe you wouldn't get from a CT, luminal imaging. So we already talked about the use of respiratory motion correction with diaphragm navigators. The problem is it's a pretty inefficient approach, and the scan time can be unpredictable. So Claudia Prieto and Renee Botner's group came up with a very interesting and sophisticated way of getting around this. It uses a 2D image navigator, which uses a low-resolution coronal image. It uses an interesting case-based trajectory that creates incoherent undersampling artifacts. They can then do non-rigid motion estimation and correction. And at the end of the day, they get, in relatively short scan times, very good, consistent image quality with nearly 100% scan efficiency. And we've started using this technique, and here on the left side, you can see a result that we got with the diaphragm navigator, not very pretty. Took over 6 minutes of scan time and had a lot of artifacts. And on the right, in about half the time, we got a much higher image quality using the image navigator, very easy to use as well. Then the technique developed by Matthias Stuber's group is a motion resolve 5D imaging, which uses a modified radial trajectory. And this can avoid the need for ECG gating or respiratory gating, and you can get some very, very pretty images with this approach as well. So I think both these approaches are very exciting and will come into use much more in the coming years. Arterial spin labeling has been around for a couple of decades. Don't see a lot of this used clinically, probably should be used more. It's more used in the brain perfusion area. And basically you substitute, instead of using a contrast agent, you use a radial pulse to tag the blood, and you get really quite beautiful images with this approach. And we used a technique called FIS, or fast interrupted steady state, that is a radial balanced steady state free precession approach that gets rid of the fat signal and is also insensitive to flow and motion artifacts. And we use this for time resolved ASL, and you can get some really interesting images with this approach. So I think this is something that could be used quite widely. You can do these images in a single breath hold. So Yes, you could do this with 4D flow, but this is, an order of magnitude faster and very visual. Alternative K-space trajectories are something to be considered. For some reason, the MR vendors are kind of stuck mostly with Cartesian K-space trajectories, which are kind of old techniques. We should be going more to the newer K-space trajectories, such as you already saw the spiral phyllotaxis approach used by the INAV image acquisitions, but radial techniques, for instance, are very motion insensitive. And here you see a comparison between radial and Cartesian KISS, where you get rid of all the ghosting artifacts. And we are using this routinely. It's not something that's commercially standard in our system, but very easy to implement. And you can just do free breathing, whole body radial acquisitions, which basically have no artifact because it's so motion insensitive. And here for screening for aneurysm follow-up, it's a very fast approach. It only takes a few minutes for whole body imaging. Here, an example of KISS, where we had someone with atrial fibrillation, where we get a lot of artifacts because of the variation in the center of K-space and the timing with respect to systole. You switch to a radial trajectory and the images look great and no problems at all. John Kotziglu in our research group has a very clever idea of taking standard 3D time of flight and saying, well, that's great, works well for carotids, intracranial circulation, but what if you could also get blood flow from the same acquisition? So he uses a multi-echo radial implementation, and in the same scan time that you normally would do 3D time flight, you can see, as on the left, you get better image quality using the radial stack of stars approach than you do with Cartesian, and you get flow imaging as well. You can do other approaches, also steady state free precession, to actually get rid of the flow signal. This is basically a FISP technique, which is about a 40-year-old technique, but now implemented much better. Here we can see a lesion much better seen after suppressing the blood flow. Here's a case where we use this to image the lungs. And we're starting to use this routinely because, for instance, as in this case, the standard scout sequences, we missed the lesion in the left upper lobe, but when you use this dark blood technique, you see this early stage lung cancer very nicely. And of course, you've already heard about AI techniques. Here's work from Claudio Prieto and Renee Butner's group using much better spatial resolution using AI techniques. So in conclusion, conscious enhanced MRA remains the most widely used approach, but non-conscious MRA can often provide comparable information, and you can get vessel wall and hemodynamic information. But a big limitation, we need the vendors to get on board to get these techniques to be more standardized, because it's too much one-off techniques from one to the other. So thanks very much for your attention.
Thank you, Bob. Maybe there is time for one single question, but we are over time already. Phil.
Bob, that's a nice overview. Your very, very last slide, your very, very last statement about getting these techniques more widely available across vendors. From your long experience, how are we going to do that?
I thought you were going to say, why bother using this? Because you can do CT, but that's okay. It's a big challenge, right? So you have some very good techniques from vendor to vendor. There's no reason technically you couldn't use any of these techniques in any of the vendor systems, because they all have pretty comparable gradients and RF and all this. There's a very much not invented here syndrome, right? So if it was developed by someone else, they don't want to use it. I don't have an answer to that. I'm just hoping, because you can do a contrast enhanced MRA that's pretty much the same on every vendor. I don't think there's a good reason why we shouldn't have the same for non-contrast, but I don't have an answer to I don't have a good answer to your question.
I think we need to move on in the interest of time. We have two new moderators. We have John and Paul coming up here. If you can get George and Ringo to join you, that would be great. But Akos and I are going to step away and leave it to the competent moderators here. So we'll move on. Thank you.
Thank you, Jeff. I'm Paul Finn from UCLA, and I'm co-moderating with John Kotzedlu from the University of Chicago. So we're now going to move on to the scientific sessions. And the first paper is Free Breathing 3D High Resolution Simultaneous Gray Blood Late Gadolinium Enhancement and MR Angiography at 3T by Dong Yu from King's College London.
Thanks for the introduction. So coronary artery disease is one of the major causes of death over the world, and it usually begins with the coronary artery stenosis and can lead to multiple different cardio diseases. CMR can allow the joint evaluation of coronary anatomy and tissue characteristics with multi-contrast images. So CMRA can provide the anatomical information of coronary arteries and the heart. While the late gadolinium enhancement is the gold standard for non-invasive myocardial tissue imaging. And recently, the gray blood LGE has been proposed by knowing the signal of the blood pool, and that can provide a better contrast than bright blood LGE, especially for the subendocardial myocardial infarctions. However, the current clinical protocols have different limitations. Firstly, the CMRA and LG are usually acquired with separate scans, which is a complex and time-consuming process. Furthermore, the CMRA and LG is usually acquired with unmatched spatial resolution and slice positions. For example, CMRA is usually acquired with 3D high-resolution imaging, while the LG is performed with 2D imaging with a relatively lower spatial resolution. So the aim of this study is to propose a simultaneous gray blood and bright blood phase-sensitive inversion recovery sequence, namely gray blood boost for one-stop imaging of 3D high-resolution gray blood LGE and CMRA. So the sequence acquires two 3D volumes interleavely prepared with inversion recovery and T2 preparation. So the first volume is prepared with inversion recovery, and the inversion recovery time is set to narrow the signal of blood pool to enable gray blood imaging. And a 2-point Dixon gradient echo acquisition is used, and two-dimensional image navigator is used to enable 100% scan efficiency, and the variable density Casper acquisition is performed with 5-fold on the sampling. For image reconstruction, inline non-rigid motion corrected iterative sense reconstruction with water fat separation is performed, followed by offline HD pros denoising and phase-sensitive inversion recovery reconstruction, and finally produce IR and T2 prep and phase PSIR images. So totally 10 clinical patients was included in this study for additional scans. 2D bright blood and gray blood LGE and 3D gray blood boost and CMRI sequences are sequentially performed after about 10 to 20 minutes post-contrast injection. And all the exams is performed with a 3T scanner using the following parameters. So all the 10 subjects successfully performed the 3D gray blood boost sequence with an average scan time about 10 minutes, and 7 of the patients also underwent 3D CMRA with the scan time of about 5 minutes. Both of the sequences was performed with a 1.2 millimeter isotropic resolution. So these are results from 2 representative patients, one presenting no LGE findings, and the other have a small amount of enhancement of myocardial scars. So first of all, the 3D PSIR gray blood boost have an excellent contrast between scar blood and myocardium, and this is similar as the 2D gray blood PSIR sequence, and that is better than the red blood 2D sequence. And the 3D results also have a good agreement with 2D images in detecting of the scar areas. And we also analysis the MRA images, and these are the curved planar reconstruction of the MRA images of the same two patients. The 3D T2 PrEP gray blood boost have a comparable image contrast and image quality compared with the 3D CMRA results according to the visual comparison. So some quantitative analysis was performed with the SoapBubble software to analyze the vessel length and the vessel sharpness. According to the results, the gray blood boost have a comparable result with CMRA regarding both LAT and RCA coronary arteries. And no significant differences was found. So in conclusion, 3D gray blood boost can achieve simultaneous whole heart gray blood LGE and CMRA in a single fast scan, and it provides good contrast and image quality comparable with reference 2D LGE and 3D CMRA sequences. Future work requires validations in more patients with coronary artery disease, and some work is also ongoing to validate the feasibility at 1.5 Tesla scanner. So thanks to the group members in King's College London, and thanks for your attention.
Thank you, Dr. C. This paper is now open for questions. We have time. So very nice work. So with your 3D acquisition for inversion recovery, scar imaging, and you're aiming for gray blood. So I guess you're aiming for nice contrast between the blood and the myocardium, as well as getting some subendocardial enhancement that's more obvious than it might be if the blood signal was too high, right? But I guess one of the issues that we encounter clinically when we're doing 2D delayed enhancement imaging is as the contrast agent is eliminated from the body, the blood concentration drops. Therefore, the ideal inversion time will change over time. You have, I think, about a 10-minute 3D acquisition with I guess, a fixed inversion time. What influence does this have practically, if any? I know you started off with some block simulations for the optimal TI, but in practice, what are the practical implications of this effect?
First of all, we did use the T1 mapping scanned before the 3D sequence, so that we use the T1 of blood to do the block simulation, so that we can get optimized the TI. Yeah, I think it is true that contrast will wash out and maybe the TI is increasing. But I think usually if we scan at a quite late time after contrast, it will become a quite stable status, and the T1 wouldn't change a lot. Yeah, I think one solution, maybe we can increase the TI time by somehow 20 milliseconds, so that we can compensate the increase of T1.
I suspect this is more theoretical than a practical problem, which I pose just to put you on the spot. But obviously, you did the initial simulation measuring the blood T1 right at the start, and I think it's a reasonable assumption probably that over the space of 5 or 6 minutes, that's not going to drift too much. So thank you. Great. Well, we move on to the next speaker.
Right. Move on to the next talk, which is titled Dynamic Ferumoxetol Enhanced Imaging with 3D Whole Ventricle Coverage using MR Multitasking. And that will be given by Shi Chen from the University of California, Los Angeles.
Thank you for the kind introduction. So long scan time is a major limitation, major issue that limits the adoption of cardiovascular MRI in daily cardiovascular practice. A recent white paper describes a standardized 30-minute cardiac MRI protocol, which can answer many common clinical questions with three major components: cine, perfusion, and LGE for scar imaging. However, typically only 3 slices are acquired for perfusion, and this whole scan requires a lot of breath holds, and it also is 2D, so there are size gaps. So ferumoxetol is a novel off-label iron-based intravascular contrast agent with long blood half-life. Previously, it has been used, ferumoxetol enhanced the steady-state imaging has been used to get cine, and multi-dose steady-state ferumoxetol enhanced imaging has been used to measure fractional myocardial blood volume. However, scar imaging is typically considered a limitation of standalone ferumoxetol imaging. So in this work, we propose an abbreviated 7-minute CMR protocol for cardiac phase resolved dynamic ferumoxetol enhanced imaging using MR multitasking, which has the potential to provide information related to function, perfusion, and scar with 3D whole ventricle coverage and free breathing. So we use multitasking to reconstruct a multi-dimensional image tensor. In this case, we have 4 time dimensions characterizing cardiac motion, respiration, T1 recovery, and DCE. So we can achieve motion resolved T1, dynamic T1 mapping. So this is our sequence. We use inversion recovery preparations, followed by 5-degree flash readouts. It's 3D stack starts radio sampling, and we have interlead navigators and imaging spokes. So we did in vivo experiments at 3T at rest, 15 subjects during slow infusion of ferumoxetol. The spatial resolution is 1.7 by 1.7 by 8 millimeter. We first did some add-on 3-minute scans with 2 milligram ferumoxetol, and then dedicated 7-minute scans with 4 milligram ferumoxetol. So let's look at some images first. This is a patient with mild non-obstructive CAD. Here we have cine, and it's and T1 recovery dynamics, and DCE dynamics for 3 example slices. And we evaluated our multitasking cine by comparing it to traditional two-phase cine, and we calculated ejection fraction in 10 subjects. These two figures show the blend Altman plots for LVEF and RVEF respectively. So they both show a mean bias of less than 5%. And this is a patient with very low ejection fraction. On the top is traditional cine. On the bottom is multitasking cine. They show great agreement. So for perfusion, we did semi-quantitative f-slope analysis of the normalized signal intensity dynamics in 3 territories of 4 subjects. The numbers are shown on the left. So subject 1 and 2, they're both healthy volunteers, and subject 3 has 2 ischemia territories according to its PET scan, and subject 4 has 3 vessel disease. So we see a significant difference between the f-slopes of non-ischemic and ischemia territories. And let's take a closer look at subject 3. On the figure on the right shows the its signal intensity dynamics and also images at 2 example time points are shown on the left. We can see hypointensity clearly in RCE at the LCX. So this is a patient with scar, as pointed out by red arrows in the LGE images at the top. And the middle and bottom row shows post-contrast multitasking T1 weighted images and T1 maps. So the hypointensity in T1 weighted images and also abnormally high T1 in multitasking T1 maps correlate with scars in LGE. And if we look at its cine and also the aconnected made to apical septum and inferior wall is also consistent with scars in LGE. So in conclusion, this study demonstrates the feasibility of a 7-minute 3D whole ventricle dynamic for muscle enhanced cardiac MRI protocol, which has the potential to provide information related to function, fusion, and scar. So that's it. Thank you for your attention.
Thank you very much for an excellent talk. Now this presentation is open to questions from the audience. Over there.
Oh, great. Thanks for letting me know.
Why did that happen? Breaking news.
Very, very nice talk. And I like to think of LGE as late gadolinium enhancement, but you were using ferromoxetol. So I was just wondering how that worked.
Yeah, so we think because ferromoxetol is an intravascular contrast agent, so the lower signal intensity probably due to the lack of ferromoxetol induced T1 shortening, it may indicate no blood supply, which is our guess why we can see a lower signal intensity and higher T1 that correlate with scars in LGE.
So thank you. If I understand right, that the LGE you showed was conventional LGE,
Yeah.
right? And then the comparison was the T1 mapping. I was just a little interested because the LGE appeared to be subendocardial infarct, and the T1 mapping showed more of a full thickness T1 decrease. So how do you explain that?
I think for the T1 map, there might be like partial volume effect because the P1 in a voxel might be a sort of a combination of different tissues, so that might make it somehow less accurate in terms of spatial resolution compared to T1 weighted image. That might be a possible reason. And but that is definitely a very interesting question. We're also trying to look into that.
Okay, yeah, when you solve that, pretty cool technique. Thank you.
In the interest of time, we'll have to move on to the next presentation. Thank you very much.
So the next talk is from Xinyu Tong, and the title is Saturated Multi-Delay Renal Arterial Spin Labeling at 5T Ultra-High Field MR, a comparative study with 3T. And Dr. Tong is from the School of Biomedical Engineering in Tsinghua University, China.
Thank you for the kind introduction. And I'm Xin Yutong from Tsinghua University. The traditional multi-delay ASL in the renal artery spin labeling provide me more accurate renal perfusion assessments but requires longer acquisition times. The saturated multi-delay renal ASL sequence can acquire multi-delay ASL and T1 map simultaneously and can provide excellent reproducibility and potential clinical value. Recently, the whole body 5T MRA can provide increased ASNR and CNR, and the longer T1 relaxation time of blood may provide the imaging of ASL. But the 5T MR may meet some challenges, including the increased radio frequency, power deposition, and fuel inhomogeneity. So this purpose of this study was to evaluate the feasibility of the semi-ROS technique in assessing the renal perfusion at 5T by comparing the imaging quality and perfusion parameters with 3T values, and to assess the repeatability of the techniques at 5T. The overall sequence structure contains the structure of that at 3T, and it includes a pre-saturation and the inversion recovery for the fair ASL and the local SPGR result. The parameters were as follows. And to address the issues of the B1 inhomogeneity between the left and right kidneys, we use the dynamic B1 shimming technique and the procedure, including a prediction of the combined B1 field distribution and the interactive adjustment of the transmit channel width. And in the procedure, a symmetrical constraint were incorporated to achieve the balanced B1 coverage. And we measure the B1 field strength to ensure effective homogenization. And for the saturation, a wet saturation scheme with 4 pulse was implemented, and the 4 flip angles was in optimization using numerical simulations. For the image analysis, all the datasets were registered using a group-wise and the registration, and the T1 maps was calculated using a dictionary-based method. The T1 maps were incorporated to the stepwise kinetic model, and to calculate the T1 RBFA bat T bat of the renal cortex. And the SNR and CNR were also calculated for the images. For the validation, and the phantom validation was performed to validate the T1 accuracy, and 20 healthy volunteers were performed the scan in 3T and 5T in random order, and the imaging was accurate twice without repositioning at the 5T. And additional 6 healthy volunteers were acquired twice with reposition in the 5T. And for the statistical analysis, we compared to the measurements and also the agreement between the 3T and 5T. As for the results, for the saturation optimization, the results show that both the phantom test and the in vivo test show that the saturation after the magnetic residual magnetization after the saturation was below 5%, and it shows the stability of the saturation. And in the phantom validation, compared to the IRSE, the semi-accurate at 5T shows that no significant difference, excellent agreement, and strong correlation, and can provide accurate T1 quantitative results at 5T. And we plot 2 examples of the comparison of quantitative results. The example 1 shows that the signal was lower decay at 5T and with the longer T-bat. And the example 2 shows that the faster decay of the signals at 5T and with the shorter A-bat and the shorter D-bat. As for the comparison of quantitative results, the T1 showed strong correlation and the RBF showed no significant difference, excellent agreement, strong correlation. However, the ABET and TBET was significantly lower at 5T. And as for the imaging quality, the SNR was 1.2 times higher at 5T of the all time of inversions, and the CNR was 1.6 times higher at 5T for the all time of inversions. And in the test of all the scan, rescan, repeatability, and scan, rescan, reproducibility with subject repositioning, and the inter-observer reproducibility. All the measurements showed excellent repeatability and reproducibility. And as for the discussion, the study showed the feasibility of similar technique at 5T, and the ABET and TBET results may be due to the B1 inhomogeneity affecting the inversion pulse efficiency, and the B1 inhomogeneity may narrow in the temporal bolus width at 5T. And the study also has some limitations. For example, the small sample size and the only relatively young healthy volunteers, and then we not measure the T1 value of blood and labeling efficiency at 5T. So in conclusion, the renal quantitative imaging with similar sequence at 5T is feasible and repeatable with significantly higher ACNR and CNR than 3T and strong interfield agreement of cortical RBF measurements. And thanks all the colleagues to this work. And this work has been accepted for publication in the JMR and it was in press. And thank you.
Thank you. This paper is now open for questions. So this is very, very nice work. I guess the challenge starting out would have been that it might be more difficult to get uniform B1 field for the inversion and so forth. And the advantage would be that the T1 is longer at 5T, so you have a longer lived bolus of blood that's perfusing the kidneys. And that seems to be what you found in your results. You also seem to suggest that there was maybe I misunderstood it, a faster decay of the perfusion signal at 5T. Why was that, do you think?
Thank you for your question. And we show that in some healthy volunteers, we show the faster decay of the signal. It may be because of that the B1 shimming the technique used in our study, only the B1 homology of the imaging slice of the two kidneys. So some other studies at 70, they use a B1 shimming technique both for the renal artery and the upper kidneys. So we guess that the 5T we also need to add the other techniques for the arteries. So.
Just one last question before you go. You did this on two different vendor platforms. Your 3T was a Philips, I understand, and your 5T was a United. What practical challenges did that present in terms of trying to make your pulses comparable? Did you have access to the same sort of pulse programming environment?
Sorry, you mean that the challenges between 3T and 5T?
Well, between two different vendor platforms, Philips and United. You don't have to give anything too much away, but it sounds like it could be challenging to try to control the same sorts of. In other words, if the only variable ideally would be the field strength, you'd want to know that your RF pulses and your shimming, B1 shimming and all the rest of it is comparable between the two platforms, no?
Oh, yes, thank you. And the challenges at 5T, yes, we try to use the advanced at 5T to improve our ASL imaging. So we want to say with the improve of the T1 values, we can the signal changes maybe longer than the 5T, and we want to know the renal artery and after the perfusion and the other procedures of the longer time. Okay.
Well, you seem to have overcome all your obstacles very well. Thank you. That's great.
Thank you very much.
Great. All right. We'll have to move on to the next presentation given by Kevin Borsos from Lausanne University Hospital in Switzerland. It's titled Deep Learning Accelerated Reconstruction of Radial Whole Heart Paramoxetol Enhanced Free Running Ultra Short Echo Time Cardiac MRI.
Okay, thank you very much for that introduction. So free-running cardiac magnetic resonance, or free-running CMR, is a self-gated continuous acquisition strategy that essentially enables us to acquire isotropic whole heart coverage during free breathing. This framework stems basically from a 3D radial spiral phyllotaxis trajectory, which enables us to extract self-gating signals, which we then use to bin our acquired case-based measurements into cardiac and respiratory motion state. So currently there's several different variants or flavors of this free running technique, including gradient echo, flow, BSSFP, as well as ultra short echo time, or UTE, which will actually be the focus of today's talk. It's important to note as well that with this framework, because we're binning into cardiac and respiratory motion states, each one of these volumes is very highly undersampled. So right now, to deal with this undersampling, we're reconstructing using a compressed sensing-based approach. This is similar to XGRASP. Here we're able to exploit the spatial temporal sparsity of this high dimensional data. So namely, we have 3 spatial dimensions as well as the cardiac and the respiratory temporal dimensions. We can exploit these redundancies within our data, and that will allow us to achieve high fidelity reconstructions. And this technique works really well. Our clinicians are quite happy with the image quality that we're able to achieve with these reconstructions. But as we know, compressed sensing being an iterative algorithm, this approach is very slow and computationally expensive. So for us to reconstruct one of these 5D data sets, it takes us anywhere between 2 to 3 hours. And so that limits the reconstructions essentially to retrospective offline implementations. And so you can imagine that severely restricts and reduces both the clinical, but also the research accessibility of the free running technique. And so for this work or this study, we're interested in developing a deep learning approach that can basically replace compressed sensing, reducing the reconstruction time to make inline reconstruction feasible for UTE free running acquisition. So like most deep learning studies, we begin with our training data. So we're working with a cohort of pediatric congenital heart disease patients. We have 50 of them. These were administered Paramoxetol, the iron-based contrast agent we've already heard a lot about. They were imaged at 1.5 Tesla with the free running UTE sequence that we have. Again, this is based around this 3D radial trajectory. So we're strictly within the 3D non-Cartesian regime here. You can see in the table the remaining scan parameters. So of note is that we have a resolution of 1.1 millimeters isotropic, as well as a fixed scan time of just under 5.5 minutes or so. And because we want to train our algorithm or a model in a supervised fashion, that requires some reference or some target images. And for this, because fully sampled data is practically infeasible to acquire, we're using the 5D compressed sensing images that we have, which are reconstructed with total variation regularization. So these are the images basically that we feed to our model or that we treat as a target when we go to train. So the network that we're working with is an image-to-image based residual convolutional neural network. This is a model that we had previously actually trained to reconstruct gradient echo data. So we took this model that reconstructs GRE data. We then fine-tuned it via transfer learning to reconstruct now UTE data. And those are the results that we'll see today. We compare our reconstructed images to the compressed sensing reference based on some metrics, including the structural similarity index, the mean squared error, the peak signal to noise, as well as, of course, the reconstruction time, which is one of our primary interests. In addition, because we want to make sure that we're not influencing or impacting the functional information from these volumes, we also evaluate the left ventricular ejection fraction. And this we compare to the measurements from the compressed sensing reference via correlation and Bland-Altman analysis. So here are some of the images that we have. So in the first column, you can see we're showing just the non-uniform Fourier transform. This is like the naive regridded reconstruction. In the center column, you have our proposed deep learning approach, and then the reference compressed sensing in the final column. So you can see both qualitatively from the images as well as quantitatively from our metrics that we can achieve reasonably good agreement with our compressed sensing references, which in and of itself is quite nice. But more importantly, we can actually now do so while significantly reducing the reconstruction time. So as opposed to taking somewhere on average of about 2.5 hours to reconstruct one of these 5D volumes with compressed sensing, our deep learning approach can achieve similar image quality in less than 2 minutes. And that's really exciting for us because that sub 2-minute time frame is now something that becomes very feasible in the clinic. And so we can also, of course, show these results in the short axis view because we have whole heart coverage, which is perhaps more familiar to some of you. And again, here we're comparing the compressed sensing images on the top row with the proposed deep learning on the bottom. And you can appreciate again that we have quite comparable image quality between the two techniques kind of across our test subjects. Looking at the measurements of ejection fraction, so here, if we look at the correlation plot, we find that there's strong correlation between the measurements from the compressed sensing references with those derived from the deep learning images. The Bland-Altman kind of reveals a bias that's very close to 0, which is good, as well as narrow limits of agreement. So these together basically suggest that our method is not, it's not compromising the functional information that's contained within these images. And that's super important because it gives us confidence as we start to roll this out in the clinic, knowing that we're not going to impact these kinds of measurements. Of course, because we have whole heart coverage, that also opens opportunities for angiography as well. So here we're showing some reformats of the right coronary artery, comparing the reference compressed sensing images with our proposed deep learning model. And here you can see that qualitatively, there are instances where our algorithm does struggle to resolve the coronaries. This is an avenue that we're currently exploring. We're kind of looking into and investigating ways that we can tweak or fine tune our model to be able to resolve these kinds of fine structure features such that in the future, we have essentially a one-size-fits-all reconstruction that we can roll out in the clinic. And so with that, today we've shown that deep learning can provide a time-efficient alternative to compressed sensing in the context of the reconstruction of UTE free-running data. We've demonstrated high-fidelity 5D reconstructions are possible in less than 2 minutes without compromising measurements of the cardiac function. And so that basically sets the stage or paves the way for us to start rolling this out in the clinic, which is something we're currently working towards, myself and colleagues. With that, I'd like to thank the group in Lausanne for their help and support, as well as my second home in Tübingen, and you all for your attention today. Thank you very much.
Thank you very much for the great talk. Now this presentation is open for questions from the audience. Hey, back there.
Sorry, I can't hear you. I'm sorry.
I believe it was, yeah.
Very nice talk and beautiful images. Could you please comment as to the size? Maybe the images, were they from adults or from children?
Yeah, so these were pediatric congenital heart disease patients. So they were mostly, they were actually all across a range of sizes. So I don't know how to go back on this, but they are from, the mean age is around 16 with a standard deviation of about 6 or so. So we had very small patients all the way up to like adolescent subjects as well.
Okay. Any other questions? I have a question. I think really impressive work how you can reduce the reconstruction time by over 70-fold. It seemed like, and yeah, my experience with some of these deep learning techniques is some of the small, fine detail can kind of be lost or muddied in a way. I know you mentioned you're exploring avenues to solve that. What would that possibly be? Would that be a tweak in the training process, or I was wondering if you can comment a little bit about that.
Yeah, I think we're really excited because there's a lot of cool things that you can try. Some of them are like super resolution, which I think we've seen already today. That's super interesting to be able to bake that in, to be able to get resolve finer structure features. Another one is also because we're working in the image domain, we are not utilizing the frequency information in K-space. Of course, that's more difficult when you have non-Cartesian acquisitions, especially 3D, but that's also something that we're working towards as well, to be able to use that high frequency information in K-space to resolve fine structures.
Okay, thank you very much. Yeah, excellent talk.
Terrific images and very good work. So your reconstruction was really accelerated relative to the compressed sensing reconstruction. What about by how much are you undersampling in the acquisition?
Yeah, so the undersampling is we treat it as a per bin because each bin is basically one 3D volume. And it ranges depending on of course, the heart rate of the patient, et cetera, how you do your binning. It's anywhere between 30 to 50 acceleration factors, which is pretty high.
Great, thank you. So the question is, by how much do you think we've maxed out the technology with the acceleration, or is there more room for more acceleration?
Yeah, I think I'm very optimistic. I'm always of the opinion we can always go higher. And I think that's actually true here as well, because we see that not every bin has uniform undersampling depending on how you do your binning. So we can reconstruct, we don't lose image quality based on higher accelerated bins versus lower ones. But I think we can definitely push it further as well. We have some interesting acquisitions as well that use a reduced scan time to look at how reducing the sort of data that you acquire can impact that. So we can definitely check as well.
This is a very hot area, and I'm sure we'll be discussing it a lot more during the meeting, but we need to move on. Thank you. Now we're on to the power pitches, and the first one is from our friend, Dr. Mackey from the University of Colorado, who's going to talk about the application of a tailored bolus injection to 3D contrast-enhanced MRA of the carotid arteries, a crossover study. Jeff.
Okay, thank you, Paul. It's a pleasure to start out the power pitch sprint here. I've had a couple cups of espresso this morning, and I'm just hoping all the other power pitch people can just be lined up and ready to go. Let's see, to go forward, I guess I do, what do I do? Doesn't work. Keyboard. Okay, my disclosures. So when we give a contrast bolus of contrast, what we want to do is to acquire the data during a steady contrast bolus. And if what happens, like shows in this picture here, where the high orders of contrast are collected during a drop-off or non-uniformity in the contrast bolus, that leads to blurring. And we have showed this before, and I've talked about this at this meeting. And one of the techniques we came up with is something called TIP, or tailored injection profile. And what you see on the top right there is a little test bolus. And from that test bolus, you can use that to try to determine what the optimum bolus would be, multiphasic in this case, to try to achieve a nice uniform contrast profile over time. So that is what TIP is it's basically a patient specific injection technique. So our study is a crossover study, single dose, multi-Hance, done at 3T. We did 10 carotid patients and we did 20 thoracic aorta patients. They either got a standard bolus of standard amount of contrast at 1.6 ml per second, or, well, they got both. And they got a TIP bolus, which was either designed for the carotid to give us a 40-second plateau or the thoracic a 20-second plateau. You can see scan times in there. The carotid was a longer scan, averaging about 40 seconds, 37 seconds, which is why we tried to have a longer plateau, a mean scan time of about 19 seconds for the thoracic aorta. We did a quantitative analysis of SNR and edge sharpness, which is 20 to 80% rise of the vessel edge in both phase encoding directions. We did it internal and vertebral arteries in the carotid, ascending, descending, and brachiocephalic artery on the thoracic aorta. This was a lot of analysis. We also did a qualitative analysis using 2 blinded readers, a Wilcoxon signed rank test for all of the things that you see here. So to quickly get to the results, the good is that we did see about 25% sharper edges for our carotid, which is the graph on the left. However, it came at the cost of losing signal to noise. The standard had more signal to noise, which you might expect because the contrast injections may be a little bit faster. As far as qualitative, all the green stars are significant. Both readers thought the standard technique had less noise. Reader 2 believed the TIP was sharper but less homogeneous. And reader 1 thought the overall image quality was better, not for the tip, for the standard study. Going to just one image here, this shows an example with the standard on the left, a tip on the right, which does have 42% better edge sharpness, but 72% better SNR for the standard. Thoracic kind of goes downhill from here. There was really no difference in edge sharpness for the shorter thoracic exam, and we once again lost signal to noise, and that was significant. Here is the qualitative for this, and pretty much there was no place where tip came out ahead in this. Overall image quality was better for both readers for standard, and then a couple of other variables where standard came out better. And then just a couple of single example here, standard versus tip. And this is a case that were near identical in terms of sharpness and signal to noise. So to just briefly conclude, I think the principle behind tip is valid. The physics behind it is valid. And you can achieve increased edge sharpness, but it's really only relevant for longer injections and longer scan times. And it is going to come at the cost of decreased signal to noise and decreased image subjective quality. So with that, I will thank you. And I do have an e-poster here, which explains this a little bit more. Happy to discuss this with anybody, but thank you.
Thank you. We have to move on to the next presentation given by Eniko Pomozzi from the Houston Methodist Research Institute, who will give a talk, Hibernating Vessels, Non-Contrast Magnetic Resonance Angiography Performs DSA in Detecting Below-the-Knee Arteries in CLTI patients.
Thank you for the introduction. I would like to share our results comparing his MRA and DSA in below-the-knee vessels in chronic limb-threatening ischemia. So progress peripheral artery disease in the below-the-knee region is quite a diagnostic challenge. These vessels are very small, often heavily calcified, and each diagnostic modality has its own limitations. Gold standard currently remains DSA, which is strongly flow-dependent and uses iodinized contrast agent. But the revascularization planning strongly depends on how well we can visualize these small vessels. Quiescent interval single-shot MRA is not a new technique, and it's widely available nowadays. It is mainly insensitive to slow flow, which allows us to visualize these small distal tibial vessels, which often remain invisible on other modalities. But the question remains, how well KISS MRA performs currently comparing with the golden standard. We retrospectively evaluated data from 41 limbs that were scanned with both modalities, totaling 570 vessel segments according to our 14 segment per limb evaluation system. First, we wanted to know the number of the patent vessel segments each modality recognizes. And also we wanted to evaluate how disease severity scores like TASC and GLASS differ from each other in each case. According to our results, KISS MRA identified significantly more patent vessel segments in the below-the-knee region than DSA, and these findings were consistent across all tibial arteries. Most importantly, in distal targets critical for revascularization planning, KISS MRA identified 16% more patent segments. The most severe lesion, classified as TASC D or GLASS 4, KISS MRA led to actually downgrading disease severity, which directly changes revascularization strategies. And most importantly, limbs that seemed like no revascularization option on conventional DSA seems like a good option and good target for limb salvage interventions. We are moving forward prospectively, and we want to test actually how KISS MRA can shorten operative time, contrast use, and ultimately eliminate the need of conventional digital subtraction angiography. And in summary, we can say that KISS MRA is not just a good alternative, but may be the new gold standard for tibial vessel imaging in chronic limb-threatening ischemia. Thank you so much for your precious attention.
That's great. And we'll move on to the next speaker. This is Vadim Malis from UC San Diego. He's going to talk about perfusion quantification in human feet with multi-PLD time-slip MR imaging.
Thank you for the introduction. So we receive research support from NIH and Canon Medical. So multi-pulse TSL can be acquired in two methods. The dark method, which just uses the specially selective inversion recovery pulses, and the bright method, which combines non-selective inversion recovery, followed by the set of selective inversion recovery pulses, and allows more explicit visualization of the perfusion signal. So the purpose of the study was to extend the general kinetic model for the multi-pulse TSL for both the dark and the bright acquisitions, validate perfusion quantification on a constant flow phantom, and apply the technique to quantify foot perfusion in healthy volunteers. So we conducted both the phantom experiments as well as the simulation, and the example images are shown on the left. So these are the phantom scans. The phantom was the constant flow water pump that was attached to the sealed water tank. You can see the difference between the dark method on the top and the bright method at the bottom. The results were consistent with the simulation results and our expectations. So for the odd number of pulses, we actually observed high signal, and for the even number of pulses due to the double inversion, there was not much signal observed. We also evaluated the perfusion coefficient from the general kinetic model, and those were in close consistency with the results that we also get from the phase contrast images by utilizing the geometry of the phantom. So those were within the 5% accuracy. So for the in vivo study, we scanned a single axial slice in the feet of the healthy volunteers. We scanned 5 subjects in total. And the control pulse was applied below imaging slab, matching the distance from the imaging plane to tag pulses and timing to suppress MT contamination in the perfusion signal. So the number of tags in the tag image was same as the number of tags in the control. In both dark and bright schemes, the 4 tags surprisingly showed the higher signal compared to 3, 2, and 1. So these are the signal increase ratio plots for the dark on the top row and for the bright at the bottom. So increase in signal increase ratio with tag number in both dark and the bright schemes was observed, with 4 tags yielding the highest and the single tag the lowest signal. As a result, from the general kinetic model, the perfusion coefficients that we got were inconsistent, and that was different from the phantom results. So for the phantom under the constant flow, general kinetic model estimates were consistent. However, for the in vivo study, the 4 tag series delivered the highest signal increase ratio and highest perfusion coefficients, which was not consistent. So more tags likely create a larger effective bolus, resulting in higher signal increase ratio. And our hypothesis is that the foot perfusion is pulsatile and heterogeneous, and a constant flow arterial input function is insufficient for impulsal data. So in the future work, we'll try to optimize tag timing relative to the cardiac cycle, and also look into the development and the testing of the pulsatile arterial input function.
Right, we'll move on to the next power pitch, which is entitled Comparison of Vessel Length Among T1 Mapping Goal Snap MRA, Snap MRA, and Time of Flight MRA, which will be given by...
Thank you. I'm giving this our research on behalf of Li Haokun. I have nothing to declare. Nowadays, non-contrast MRA technique like TOP MRA is very widely clinical used. Technical snap could simultaneous imaging lumen and vessel wall, and the Go snap is an extension of snap which allows the reconstruction of multi-TI weighted imaging and giving the T1 mapping. So this study compares among these 3 MRA techniques cannot be done on intercranial artery. This study compares the vessel lessons of brain GoSNAP MRA, SNAP MRA, and TOF MRA to assess the ability of visual imaging of the imaging technique on intracranial arteries. We acquired data from 7 patients, each with all the 3 sequences, including TOF, SNAP, and GoSNAP. To calculate the resolution, we co-registered all images of each patient, use simple ITK, and crop the FOV to the same level, and analyze using ICFA, a software for manual intracranial artery tracking and feature extraction by a junior reviewer under guidance of senior radiologist. Total number of branches is defined by the number of bifurcation points in the cerebrovascular structure. Wilkinson signed rank tests were performed to assess the significance of difference of each metric. Here are the results of the comparison. As the visual length, the results are shown as the mean value plus or minus the standard variance. Although due to the relatively small numbers of total cases, a significant difference is not yet observed. It concludes that GoSNAP MRA has potential to visualize more artery than TOF MRA and SNAP MRA. This superiority is mainly in image of MCA. The number of valid branch doesn't have an obvious difference between the 3 MRA techniques. Here are example of the intracranial artery tract of the 3 MRA. It can be seen the GoSNAP MRA has potential to visualization more intracranial artery than the other 2. It can be concluded that the GoSNAP MRA has potential to visualization more intracranial artery than SNAP and the TOF. In the future, more data should be included. That's it. That is. Thank you for listening.
Thank you very much. And the next power pitch is given by Giles Raditi from NHS Greater Glasgow and Clyde, UK. He's going to talk about gadaquatrain at a 60% reduced gadolinium dose for MR angiography of intracranial vessels.
Good morning. This is a sub-study of the Quanti CNS phase 3 study of gadaquatrain. These are disclosure of conflicts of interest. Gadaquatrain, if you're not aware of it, is a new tetramer. It has 4 gadolinium atoms compared to the single atom you're used to for most gadolinium agents. It's got a very high relaxivity per molecule, as well as a high relaxivity per GAD atom. It has also, interestingly, low viscosity and low osmolality, very similar to blood. And like the other macrocyclic agents, including the new ones, it's got very, very high stability with no measurable GAD release. The study design and objectives, this was the overall Quanti CNS. So this was for 305 patients, intra-individual comparison randomized trial, whether they got, the centers were blinded as to which agent the participants were getting. We just looked at the sub-study of these who actually had MRA as part of their CNS. We didn't mandate MRA, so only 14 patients actually had MRA as contrast-enhanced MRA as part of their study. So we just looked at these for this particular sub-study. We looked at pre-contrast images compared to post-contrast as part of the FDA approval process. They demand pre-contrast studies to show that. So obviously we show that with adding contrast, we get better visualization. There was clear improvement achieved for all the visualization parameters for the readers. It's all quite not very exciting, but here's the images. So you can all be readers if you want to blind yourself to which patient got the standard of care agent versus the lower dose gadaquatrain. You can decide for yourselves which images you like better from some of these patients who were referred for varying indications, including this patient who actually had an aortic dissection. And you can see the difference between the gadaquatrain and gadabutrol for that patient. And then a further selection of patient getting various contrast-enhanced MRA of the carotid and vertebral arteries. Very similar results, I think you'll all agree, for the lower dose gadaquatrain versus the standard of care agent, all getting identical parameters, all on exactly the same systems. This would mean nothing if the agent wasn't safe and it had very low incidence of adverse events, very similar to the standard of care agent. So we don't see any issue there. And so our conclusion is that at a dose of 0.04 millimole gadolinium per kilogram body weight, which is a 60% reduction in dose compared to standard agents, then we have consistent and similar results for contrast-enhanced MRA for the CNS and adjacent vessels. That's really all I have to say, so I can move on. Thank you very much.
The final power pitch of the session will be given by Enrico Pomozzi from Houston Methodist Research Institute. The talk was titled MRI Histology Identifies Impenetrable Plaques Not Seen in Conventional Imaging, an Amputated Limb Model, and Protocol to Cross Impenetrable Lesions, and from Semmelweis University too.
Thank you so much again for the introduction. This time I would like to present our novel ultra-short echo time MRA technique and how it can actually predict crossability in vascular interventions. Peripheral artery disease is a major global burden. In every year, nearly 500,000 new cases of chronic lymphocytic ischemia emerge, and about 22% of these patients face major amputation or even death within 1 year. And these numbers are even worse with diabetes. We perform vascular interventions every single day, but we still lack one critical piece of information about plaque composition. And we believe this is why our interventions fail at the very first step. Up to 20% of the cases, we cannot even cross the lesion. But whether a lesion consists of mainly hard or soft tissue, it can directly determine crossability, thus procedural success. Our study group has a very unique workflow. We obtain amputated limbs from advanced CLTI patients and perform ex vivo imaging on them, followed by intervention experiments and vessel harvesting, and then histology analysis. Our imaging is based on an ultra-short echo time MRA with unparalleled ability to actually distinguish soft and hard lesions from each other. So far, we examined 39 patients, resulting in 67 arterial steno-occlusive lesions. In our data set, 74% of the lesions were hard, while 26 were soft, according to their major dominant tissue composition. So in our ultra-short MRI images, soft tissue appeared to be this ISO or even more hyper-intense, and in our color-coded maps, they are this kind of deep blue color. Only 7% of these soft lesions were non-crossable. Hard lesions are very dark because of rapid signal decay, and for example, calcium is like completely black and is purple on our color-coded images. 72% of hard lesions considered to be non-crossable during our intervention attempt. And it doesn't matter if a hard lesion is consists of like hard collagen or calcium, the chance to cross them remain very low. Most importantly, our MRA findings had 100% corroboration with histology analysis. The message is simple. Plaque morphology matters. Hard lesions are less likely to be crossable, which place our patients at high risk of interventional failure and vessel wall injury. Our ultra-short time MRA can actually differentiate hard and soft plaques from each other. And this information can transform patient care and actually improve the outcomes of peripheral vascular interventions. Thank you so much again for your attention.
So that concludes the power pitch session. I encourage you to all connect with the speakers because there is no dedicated QA section for the power pitches during the breaks. So on behalf of my co-moderator, Dr. Finn, I'd like to close this session and head off to Dr. Collins.
Thanks. Just a quick announcement. Want to thank all the speakers this morning. Great sessions. Nice to see us see so much science happening so quickly. So again, like John said, please connect with them during the breaks. For those of you who received invites to attend the Insight Forum, I'd ask you to get the food from outside and then go to seminar rooms 1 and 2, which are just on that side. So as you face the lecture hall to your left, and we'll get started there in about 5 to 10 minutes for the Insight Forum. And we'll reconvene in this main room at 2 o'clock. Thanks again for the excellent talks and discussion this morning.
Right.